In adenomyosis, it's a conservative management if it's focal, while in myoma, it's a surgical one. So not to be blamed for a patient underwent surgery for a focal adenomyosis called by mistake as a myoma. Moving to endometrial cancer, and this is a staging of endometrial cancer. I better show you by pictures. This is a stage 1A in sagittal T2WI. It's difficult to delineate the outline or how invasive is a tumor towards the myometrium, and same in the axial. And it's better seen here when we give contrast. This is a tumor filling the endometrial cavity. This stage 2, a tumor clearly going to and invading the cervix. That's stage 3A, the tumor has been going beyond the outline of the uterus. And this is again stage 3B, where you can see lymph node involvement around the uterus because the tumor is spreading beyond. And here are also lymph nodes. Important to know and to understand that uterine carcinomas spread to para-aortic lymph node, internal iliac lymph nodes and para-aortic lymph nodes, while cervical carcinoma, as we are going to see later, they are going first to the parametrial lymph nodes, then to the external iliac lymph nodes, and then to para-aortic lymph node. It's more like systematic or step-by-step lymph node invasion. That's stage 4 endometrial cancer invading the urinary bladder, as you can see here in different planes. In diffusion, it's restricted diffusion and low signal on ADC, and of course it's enhancing. Uterine sarcomas or leiomyosarcomas or sarcomatous transformation of myoma is also a common question in the clinical practice. When to suspect sarcomatous transformation? When we see large size of the myoma, if it's exceeding 10 centimeter or more, with heterogeneous signal intensity, as you can see here, with areas of hemorrhage and necrosis. That's a post-contrast. You see areas of non-enhancement because of necrosis. And the second or the third important point is the outline of the sarcoma is ill-defined and invasive, unlike the myoma, which will be more well-defined. Moving to cervical cancer, and here it's easy to detect a mass coming from the cervix. Very important. When we talked about the zonal anatomy of the cervix, we talked about the outer zone, which is hypointense. Look here in axial T2, you can nicely see the hypointense frame of the outer zone of the cervix, unlike here when the zone is disturbed and there is a mass fungating or invading beyond this outer zone. So it's clearly a stage 2B cervical cancer. So it's a bottom line here. If you see the outer zone of the cervix clearly all around the cervix, so the tumor has not invaded the parametrium yet. That's the staging of the cervical cancer. And of course, stage 2B means there is parametrial involvement. It's important in the therapy. Again, a tumor invading the outer zone of the cervix towards the parametrium. So this hypointense rim sign is your friend when you deal with case of cervical cancer. That's stage 3. The tumor has been invading the lateral pelvic wall. And here, stage 4, the tumor is invading the rectum, as you can see here and here. As mentioned, cervical cancer is spread to lymph nodes stage by stage, starting from the parametrial lymph nodes around the cervical canal, and then going to the lymph nodes of the external and common iliac veins, pre-sacral lymph nodes, and then para-aortic lymph nodes. That's how we look at lymph nodes metastasis. And here, when you are looking for lymph nodes, T1 is your friend. Why? Because we are using the natural background of pelvic fat, which is hyperintense, as a contrast. So you are looking for hypointense lymph nodes on the background of hyperintensity of pelvic fat. Patients with cervical cancer subjected to therapy like radio, chemotherapy, and coming for follow-up, we have a problem here because radiation-induced scar in the beginning, they are having inflammation, edema, neovascularization, and all that will induce T2 hyperintense signal, same like recurrent or residual tumor. So differentiating post-therapy changes from real tumor is difficult in the first 6 months. That's why we prefer the follow-up to be postponed after 6 months from therapy. However, in some clinical scenarios, it's not always possible. That's indicates using other like tools, like adding or using diffusion and dynamic post-contrast acquisition to differentiate both. This is a cervical cancer with therapy. You can notice the tumor is having progressive shrinkage with therapy. And this is one of the complications of radiotherapy. There is a fistula from the cervix towards the urinary bladder. Moving to ovaries, and starting with the benign ovarian neoplasm, benign germ cell tumor like macrocystic teratoma or dermoid cysts are by far the most common most common benign ovarian tumor, usually discovered incidentally in a young woman, and it's not unlikely to be bilateral. It's a mixture of tissue, but we definitely love to see the fat, which is diagnostic of that kind of tumors. The fat could be macroscopic, so it's hyperintense on T1, and definitely couple it with T1 fat suppression to make sure it's getting suppressed and it's not blood. T1 hyperintense lesion in the pelvis might be blood or fat. So do look at T1 fat suppression. If the lesion is suppressed, this is fat. Usually it's a teratoma or mature cystic teratoma. If it's not suppressed and stays hyperintense, so that's blood, and accordingly we will give the diagnosis. Sometimes this fat is microscopic. You cannot see it by eye, or sometimes if the dermoid has ruptured. So the tool here is to do one of the chemical shifts phases, in phase and out phase, in order to detect microscopic fat. That's a straightforward case of dermoid cyst being hyperintense on T1, completely suppressed on T1 with fat suppression. The second benign tumor is the six-cord stromal tumor, which includes fibromas, thecoma, and fibrothecoma. These tumors are rich in smooth muscle, so they are looking hypointense on T1 and T2 weighted image, and they behave same like the muscles when we give contrast. Important to know that these ovarian fibromas might reach large size, more than 10 centimeter, and accompanied by pleural effusion and ascites. This syndrome is called Meigs syndrome. When the tumor is surgically removed, pleural effusion and ascites will disappear. This is an example of a thecoma. There is a tumor arising outside the uterus. It's quite large, and we will see later when the tumor is large, localizing the origin of the tumor might be difficult. But looking at the signal intensity and the pattern of enhancement, this is a contrast study. the tumor or the mass is following exactly the adjacent muscle enhancement. The third benign ovarian tumor is epithelial ovarian tumor, including serous cystadenoma and mucinous cystadenoma. This is an example of serous cystadenoma, which is a unilocular cyst, fluid containing, hypointense on T1, hyperintense on T2, no enhancement, no papillary projection, no septation. While in mucinous cystadenomas, the cyst is multilocular. You will see multiple septations. It's quite larger in size. And because the mucin contents inside the mucinous cystadenoma is variable, you will see different shades of hyperintensity on T2WI. Here, look at the septal thickening and look at any papillary projection or enhancement pattern, because here we need to stop and compare or raise our awareness about when to call a lesion suspicious. If a lesion is larger than 4 centimeter, have septal thickening which is more than 3 millimeter, any papillary projection, any enhancing soft tissue component, or any associated findings like presence of ascites, presence of peritoneal nodules or lymph nodes. These are all like suspicious findings. Since we are acquiring dynamic post-contrast series, we acquire dynamic curves. You know, type 3 curve, which is of rapid uptake, rapid washout, is the suspicious curve for malignancy. Just a quick word about ovarian tumor in children. If the girl is more than 9 years, it's probably benign. Lesion may be more common to be like a simple cyst or follicular cyst or mature cystic teratoma, while if the lesion discovered in less than this age, it's probably malignant. When we see adnexal lesion in pregnancy, the majority will be mature cystic teratoma, maybe cyst adenoma, functional cyst, and the least likely is a malignant lesion. This is an example of ovarian malignant lesion showing solid and cystic component, heterogeneous enhancement with areas of non-enhancement, areas of diffusion, restriction, and the curve is a type 3, which is rapid uptake, rapid washout. Associated multiple peritoneal nodules, which support our diagnosis of malignancy. Looking at the nodules at the whole peritoneal membrane, especially at the subhepatic or at the surface of the liver, and here's the superiority of MRI in detecting nodules in diffusion compared to even T2 and in CT.